This
Thanks.
conference will now be recorded.
Thanks, Brandon. Contrast that with another patient that we saw, same similar story. Notice the lump in his arm, his left arm. PCP again moved it around, thought it could come out in the office, but then the patient wanted to come see us. So we got another MRI scan, and this one looks different. I hope you can see that the image, particularly on the right, just looks different from that last patient with the lipoma. So we got a biopsy, and this is some additional cuts of it. You can see that the mass just isn't looking exactly like the sub-Q fat, and it seems to be a little bit more infiltrative. So we got a biopsy, and that showed high-grade spindle cell sarcoma with a very high Ki-67. This patient got neoadjuvant radiation and radical resections, and this is the picture from the operating room where we've cored out most of his triceps muscle down to the level of his humerus to get an appropriate margin around that and some big skin flaps. So same general lump, same general thoughts by the PCM, but completely different approaches to workup and surgery. Third patient, 58-year-old woman had noticed a lump in her thigh. Again, got an MRI, and we see this really T2 bright mass in the lateral left thigh. But it also looks funky on the contrast-enhanced images, so we got a biopsy, and that came back as a myxoma, and we'll come back on that later, a little bit later, but we had to do another pseudo-radical resection on her. Finally, 71-year-old comes to your office with a lump in her belly. She says, I feel full early, and I'm just noticing that my belly feels firm on the left side. So we get some scans, and Kai, what do you see on these scans?
So on the first image, it looks like it's a relatively well-defined mass in the left upper quadrant just next to the spleen. It's sort of a mixed density. As you come lower down by the kidney, it loses some of that definition versus, I can't tell if that's just fat stranding. And there's definitely some edema in the tissues down lower as well. Very concerning for malignancy.
Yeah, very concerning.
Yeah.
Yeah.
I can't really tell as far as vasculature and stuff what's going on in that picture,
Yeah.
but
We'll talk about
AV
this.
normal.
Yeah, that's definitely abnormal, and we'll talk about how it's abnormal in a lot more detail in a little bit. So this patient has a retroperitoneal sarcoma. This particular patient got pre-op radiation, then a radical resection where we took out all the tumor with the distal pancreas, the spleen, the left colon, and the left kidney, then hooked her back up together, and she did fine afterwards. But so this runs the gamut. These are all to show you. The final path on this was something called a dedifferentiated liposarcoma, which we'll go into as well in just a little bit. So I hope this shows you kind of a gamut of lumps and bumps. Some of these things are totally benign, and by and large, when we're looking at the sub-Q things, they're totally benign. But the further deeper and more central we get with these things, and the uglier they look on imaging, we can get into some very ugly tumors that require extensive surgery to treat. So today's outline, we're going to talk about the workup in general when a patient comes to your clinic with a lump. And first off, how to name it, and then how to get it appropriately staged. And then I'll talk about some broad concepts about treatment for these things. I can tell you a couple of sticking points. The first sticking point is the mainstay of sarcoma treatment in people with localized diseases, surgery. And so that's why this comes up again and again on boards, and why these patients, if they come to you with a soft tissue tumor, your first question is, can I safely get it out? Like we talk about with most other localized tumors. So first, naming and staging it, right? I know we talked about this in boards prep, and it applies to real life as well. Three main things when dealing with a tumor of some sort: name it, stage it, treat it. In particular with soft tissue tumors, in naming it, we rely heavily on imaging, and then a biopsy if the imaging is suspicious. We stage it. Sarcoma staging has gotten extremely complex. It's a 3 or 4 factor staging system, but it boils down into 2 groups: high risk, which are large, deep, and high grade, or not high risk. And the treatment for both of those is slightly different, and we'll go into that. And then treating it: surgery, 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 sometimes radiation, sometimes chemo, but in very select cases. For the imaging for soft tissue masses is very simple. If it's on the extremities or trunk, and that includes the abdominal wall, get an MRI. If it's intra-abdominal, get a CT with contrast. Before we get into it, so in terms of the extremity soft tissue tumors, that's it. You just need to get an MRI and then figure out what it looks like on MRI and then biopsy it if you need to. With intra-abdominal tumors, particularly, we'll get a lot of referrals for people with retroperitoneal tumors. So it's important to know the differential for retroperitoneal tumors and how that influences your workup in clinic, because these patients will frequently come to you incompletely worked up. So 1 second, I just want to see what we have on here. We're going to start low. I saw Bobby. Bobby, what is on the differential for a retroperitoneal tumor? And say you haven't been able to look, you haven't gotten a chance to look at their imaging.
Okay, I think the differential includes lymphoma, liposarcomas, leiomyosarcomas.
So sarcoma in general, yes. Lymphoma, yes. What else?
So this is just a retroperitoneal mass, you're saying,
Yes.
or like a myo, just like a lipoma. I don't like a.
Yeah, there's all kinds of omas, but also think about, particularly in men, there are retroperitoneal masses that men get that women don't get.
Nerve cell tumor, like testicular.
Yes, yeah. So in general, four main things you want to have in your mind, because we can test for these pretty easily. Like I said, lymphoma, germ cell tumors, particularly in guys. So metastatic testicular cancer goes preferentially to the retroperitoneal lymph nodes, and they can get huge when they have retroperitoneal nodal mets. Undifferentiated carcinoma, NOS, and then sarcoma. So for these, the imaging is very helpful to figure out between the two. But before you look at the imaging, what this means in your workup is you want to check for lymphoma symptoms and testicular cancer symptoms. So Bobby, what are some lymphoma symptoms?
So like fevers, night sweats, weight loss.
Good.
Cough, lump.
And then testicular, how do you check for metastatic testicular cancer?
Say it again. Sorry.
So to evaluate for testicular cancer.
Enlarged testicles, testicular mass, firmness. You can, I guess, forget like the light tests, whatnot.
Yeah, just do a testicular exam. So if it's a guy with a retroperitoneal mass, always do a testicular exam as part of your initial workup. So you said everything else exactly right. For lymphoma, ask about B symptoms, so fevers, night sweats, unanticipated weight loss. In the family history, if people have a certain family histories of cancers, that can help steer you one way or the other, but it's not as much helpful for the rest of your exam in the imaging. And then make sure to go over all their nodal basins, because if it is a retroperitoneal lymphoma, you want to see if they have, neck lymph nodes, axillary or inguinal lymph nodes in addition to it, so you have something that maybe you can biopsy and spare the morbidity of a retroperitoneal nodal biopsy. Finally, for the labs, for the lymphoma, basically LDH and a white cell count should be all really you need. And then for the germ cell tumors, HCG and an alpha fetoprotein in guys, because if they're markedly elevated, that would be helpful for figuring out whether that's a testicular tumor. And then finally, the imaging to seal the deal. So for retroperitoneal masses, a CT with contrast is very helpful for 3 reasons. One, gives you a sense for whether there's any metastatic disease in the liver. And then for the kidneys, you want to see how they enhance, because if this is a tumor that's involving the kidneys' blood supply, you may see that it's already kind of taken out, and you have a little less hesitance to remove the kidney to get a wide margin in that case. On the flip side, if this patient only has 1 kidney, you got to be careful about how you're going to approach that. And that's why the CT with contrast is helpful. Okay, so with that in mind, let's ignore that and see who's around else. Shai, do you have video capability? Great. I want you to walk me through this scan. This is patient 1. Tell me about this tumor. How does it look?
So this is a 6 by 5 centimeter tumor that's isointense with the surrounding subcutaneous fat. Doesn't appear to have any sort of gross involvement or extension beyond the capsule of the tumor based on this. And it's relatively homogeneous.
Yes, all those things. So one, superficial or deep? This is superficial, right? It's right underneath the skin. Doesn't seem to be heterogeneous. It's got few to no septations. Looks pretty bland. And it's the same, like you said, the same intensity as the subQ fat. When you put all these things together, this says to me it's either benign or a low-grade lipomatous tumor. Contrast it, Justin, with this scan. This is from the thigh of a 50-year-old man.
So that's a deep tumor that's heterogeneous in its texture, and it's not the same isointensity as the surrounding fat. It's got some areas of looks like maybe contrast uptake.
Yep, all those things. Deep, heterogeneous, like you said, different intensity as the subQ fat and muscle. And this is also a contrast enhanced image, so you see that it's enhancing heterogeneously as well. This is probably sarcoma, and it's probably high grade based on how large it is and how ugly it looks with the contrast enhancement. So this is something you would want to biopsy. Okay, is Sarah? Sarah's there? Which Sarah?
Yeah.
Thomas, you here?
Uh-huh.
Good. Tell me about this scan.
So that is a deep lesion in the intra-abdominal cavity that is maybe a little rim enhancing and looks sort of cystic, like fluid filled.
What else about it? What do you notice that it's doing to the other abdominal viscera?
It is displacing it.
Yes, yeah. So what looks like cystic is not. It's abnormal fat. And this is going to go, we'll talk a little bit more about this in detail down the road, but something that kind of, at least raises my suspicion for retroperitoneal sarcoma is how the fat looks. And just keep looking at CTs and we'll get a sense for this, but you see these large lobules, and that's what the kind of the medium gray is, those large lobules of abnormal fat. And those light areas of gray are the septations within that abnormal fat. You also notice that the right kidney, or sorry, the left kidney is getting pushed slightly up, and then all of the hollow viscera, so all of the GI tract is getting pushed way anterior. So all those things say to me that's retroperitoneal liposarcoma. And well-diff, the abnormal fat is well-differentiated liposarcoma. And the arrow in this particular shot, because I got this from one of our med-oncs, the arrow on this shot is going to like a not exactly cystic, it's just more, it's enhancing more, and that area where it's hyper enhancing is probably a dedifferentiated component. So we call this well-diff, D-diff liposarc. They frequently run together. So finally, so now we have a sense for, thank you, that's great. You got a good job naming all those things. Now let's talk about how they're going to go over the long term. So the problem with sarcomas is that their natural history is driven by histology, size, and location. And the problem with that is there's over 80 described different histologies of sarcoma, and they all behave slightly differently. So on the screen left, you'll see how different retroperitoneal sarcomas form metastases by their histology. The top line is leiomyosarcoma, so about 60% of patients with retroperitoneal leiomyosarcoma develop metastases over the course of their lives. Contrast that with the bottom, the red line, which is well-diff liposarcoma or myxoid liposarcoma, where only about 10% of them will develop a metastasis over their lifetime. Those sarcomas tend to recur locally and not distantly. On the right side of your screen is disease-specific survivals, and that means are patients dying from sarcoma, and that is just within the subset of fatty tumors, the liposarcomas. The myxoid and well-diff, the red line and the green line at the top of your screen, those tend to live, people with those tumors tend to live a long time, even with tumor, as opposed to the pleomorphic and the dedifferentiated, the yellow and the blue lines at the bottom, where those patients develop metastases and die from sarcoma, unfortunately, very commonly. You don't need to know the ins and outs of these things. This is just to illustrate the importance of knowing the histology of these things when you're developing a treatment plan. The natural history is also determined by the size of the tumor itself. So for
Dr.
patients
Corral, sorry to interrupt.
with myosarcomas, those who are presenting with a primary tumor greater than 10 centimeters are far more likely to die from their sarcoma than those presenting with those less than 5. Reason being that they think if they let it go that long, if it grows that large, they've either let it go long enough for it to maybe send out some metastatic, or it's an aggressive enough tumor if it's growing that fast. And this will apply to other tumor subtypes as well. And then finally, where these things present also influences it. So patients with retroperitoneal or intra-abdominal sarcoma are more likely to die from their sarcoma because of the downstream effects of what it does to the other stuff in the belly, as opposed to those who present with extremity sarcomas, because we have very effective local treatments for those. Again, you don't need to know all the specifics of it, but know that the histology, the size, and where it comes from are the primary drivers of how patients do with these over the long term. So I've got a question from a board standpoint about the histology. Yeah, we'll get into that a little bit. I've got some things for you. No, so retroperitoneal tumors, by far the most common one is liposarcoma. Extremity tumors, it's a big mix of things. But I hear you, Kai. We're getting there. Okay, to go back. Let's see. Tommy, you still there?
Yeah, you might get some other noise too, but
Birds and squirrels. Excellent.
something like that.
So here is your patient, a 50-year-old man in your clinic with a left thigh mass. We've seen one of these scans earlier. I'll tell you right now, you get a CT scan that shows he's got a 20 centimeter anterior compartment thigh tumor. You get an MRI because you know that's what you wanted. That's a better way to assess these things. And this is what you see. On T2, it's bright and heterogeneous. That's on screen left. And post-contrast images show that it heterogeneously enhances. What do you want to do next?
Other than focused history and physical, I would like to get a core needle biopsy.
Great. Core needle biopsy is exactly right. It's the preferred. You can do it in clinic. We don't do it frequently here, but I've done it in other patients here. Their other reason is if you send them to like a medicine doctor, they're just going to drag their feet generally, unless they're sarcoma specialists. So if you have the opportunity, just do it yourself. So biopsy in line with your planned resection. Why is that important, Tommy?
Especially on the extremities, you want to have a longitudinal biopsy. Not really important for core needle, although any excision will have to excise that tract. So you don't want to take a crazy route to something, but especially for something that you have to do an incisional biopsy, you want to make that incision longitudinal along the extremity, so you can remove that later if it turns out to be cancer like you expect.
Yeah, longitudinal is helpful for the incisional biopsy. I'm sure they're still teaching that. Core biopsy is almost negated the utility of incisional. If you're out in the bush and you don't have access to all that stuff, then sure, do that. But otherwise, use a core, because a core biopsy, resecting that tract is a lot easier than ellipsing out an excisional biopsy tract and the stuff that you do. So for this patient, we did a biopsy anterior. That's a great route because we knew that for an anterior thigh mass, we were going to be doing an anterior incision. What is not okay is doing a medial approach or a posterior approach. And the reason is just like you said, we take out that biopsy tract because there is a theoretical concern of tumor seeding. And taking out a medial track approach for there, even though that is technically doable, you know, like an RIR guys say that's a chip shot for us. They're not necessarily thinking about the downstream surgery we have to do. So if you're not doing the biopsy yourself, this warrants a phone call to whoever's doing it to let them know exactly where you want them to do it. And I've had to do that a couple of times in my career where like if I just didn't have the stuff in clinic, but we had the core, I put a mark on the patient exactly. I said like biopsy here. So this patient's pathology came back high grade myxofibrosarcoma, which doesn't mean much now, but we'll get into it. So now we got to stage it, right? And so it's this one is high risk. It's large, it's 20 centimeters, it's deep, it's right up on the bone, it's high grade because we've been told that or not. So we need to complete his workup, and for most sarcomas, that is getting chest imaging. And if it's a low-grade sarcoma, the chest X-ray is fine. For a high-grade sarcoma, we usually get CT because we're getting CTs for other reasons anyway. So low-grade X-ray, high-grade CT. Bonus question: who gets a CT of the abdomen and pelvis for an extremity sarcoma? This is like totally up Tommy's alley.
I mean, anytime it would be in the groin, I would also include the abdomen and pelvis.
Very good. But who else? So say it's a thigh or a calf tumor.
I mean, a child, pediatric sarcoma.
Good.
Just, some of them are hereditary with syndromes.
Very good. The one I'm asking for is something called myxoid liposarcoma. And the reason is this is a particular tumor for whatever reason that can metastasize to the fat pads in the pelvis, the retroperitoneum, the supraclavicular fat pads, or the mediastinum, or the breast. We've seen myxoid liposarcoma metastases to the breast. So if you have that particular histology, we always got comprehensive CT imaging. The other thing that can happen is it can go to the spine. So if there's any concern for back pain, we get a spine MRI with it. So Kai, to one part of your question is, this is an important histology to know, myxoid liposarcoma. One, because it behaves in a really weird way. We do extra staging for it. And two, I'll talk about it later, we treat it slightly differently than the other liposarcomas. Is Sheckman there? Not okay. Sarah Thomas, double bonus. Who gets lymph node meds?
I don't know.
That's fine. This is total absite fodder. And Kai, again, this is like absite stuff. This should not really, I hope, show up on your oral boards because it's kind of pointless. Epithelioid, clear cell, angio, and rhabdomyosarcoma can go to lymph nodes more frequently than other sarcoma types. The prognostic implications of this are a little bit unclear, or I mean, the prognostic implications are if they have lymph nodes, they're categorized as metastatic disease stage 4. The treatment implications are unclear. Some surgeons do sentinel node biopsy on these kind of tumors. We did them a lot for the epithelioid tumors at Sloan Kettering, but they almost always were normal, and it didn't really change how much we did. We didn't do like a completion node dissection or anything like that. But this comes up occasionally on multiple choice tests, which of the sarcoma subtypes have lymph node metastases, and it would be primarily these 4 types: epithelioid, clear cell, angio, and rhabdo.
I think synovial does too, and the only reason why I mentioned that with this is because if you add synovial in there, it's an anagram and it says scare,
Nice.
SCARE.
That breaks down a little bit because the most common ones we encounter with lymph node mets are called UPS, undifferentiated pleomorphic sarcoma, which is just a catch-all for high-grade sarcoma that we can't figure out anything else. But
so Tommy, so there is a lot of controversy about this. Synovial is taught by some people and not taught by other people. I use the acronym RACE, RACE, and then I used to say races, and now I change it to RACE-U. So RACE plus either synovial or UPS should get you what you need for the absite. But the synovial is very controversial. I think an old question 5 years ago probably would add synovial. If somebody's keeping up with the literature now, synovial really shouldn't be on there, but UPS would be.
Yeah. And again, takeaway, that's just like ABSI trivia. From a clinical management standpoint, it's all over the map. Sentinel node biopsy may help you diagnose metastatic disease, but we don't know always what to do with that information. So something to be on the lookout for. So if you have somebody with one of these histologies, evaluating their lymph nodes may be helpful, so you can help stage them further. Okay, so that's naming and staging. There's all, like I said, the stage is driven by grade of the tumor, high grade, how big it is, and how deep it is. So deep tumors, greater than 5 centimeters, high grade, those are stage 3s, and those typically get multimodal therapy. Superficial tumors, even if they're high grade, it becomes a lot more complicated. And some certain tumors are, like, by definition, high or low grade. So for example, a cutaneous leiomyosarcoma is always low grade, no matter what it looks like under the microscope. Again, you don't need to know that, but I'm just saying it's a complicated system, and that's why this is one of the things where I keep my tables and books in front of me whenever I'm seeing sarcoma patients. And Kai, for the purposes of the boards, they're not going to go into the weeds of those kind of things. They're going to want you to know how to work up a mass and how to, when you would think about multimodal therapy for the masses. So that's what we're going to get into now. So treating these things, broad concepts about surgery, chemo, and radiation. Historically, the surgical treatment for extremity sarcoma was amputation one level above the tumor. So for example, a calf tumor would get an above knee amputation, a knee tumor would get a hip disarticulation, and a thigh tumor would get either a hip disarticulation or like, the leg off. That's why sarcomas have historically been very much feared by patients. We're getting better. Radiation, like all other local therapies, it's a local treatment. It decreases local recurrences for high-grade extremity tumors. It has no impact on distant metastases. It has no impact on disease-specific survival. It has no known therapeutic relevance in retroperitoneal sarcoma, but that is highly debated. Chemotherapy has shown no survival difference in low-grade tumors and variable advantage in high-grade tumors because it depends on the histology. So, like I said, now historically we did one amputation. We did an amputation a level above the tumor because that was the only treatment we had. But now limb-sparing surgery is standard. We amputate in certain cases, and these may come up. The first is that the limb is already functionless, rendered by the tumor. It's encroaching on nerves, vessels, and rendering the limb functionless. And the resection couldn't achieve a clear margin otherwise. Or there's circumstances where there's a local recurrence and there's no other local therapy options, then amputation is certainly reasonable. Other than that, we do everything we can to preserve that limb. To plan for your surgery, one, review the anatomy. And this is like get out of netters. And our attendings would still do this at Sloan Kettering. Every time we were planning a case, we'd go through some netter slides with them. Second is determine the margins from your, yeah, it is hard because they go to ortho. Yeah, I'm trying to work on that for what it's worth, Kai. We did everything that weren't bone sarcomas in my training, so we had free rein. That's why there's a lot of these thigh patients on this thing because, oh yeah, nice. That's why we do these thigh patients are the challenging ones from a technical standpoint. So you got to know your margins, and to know your margins, you really need to know your anatomy, and then determine what you need to avoid so that you can keep the limb functioning. So, for example, this is a myxoid liposarcoma near the knee. It's also on the medial. It's on the medial knee, and so it's by and screen left. You can see it's by the saphenous vein, which who cares about that? But as one goes deeper, you need to start considering the femoral vessel, the sciatic nerve, and the popliteal artery, and you want to make sure that you preserve those things so you can give the person some leg function down the road. Determining the margins. So Akai, this is another one of yours. Myxofibrosarcoma. It spreads along fascial planes. That's one of the things that makes it a little bit more unique than the other tumors. And what it translates into, you need to get wider margins. On screen left is an arm myxofibrosarcoma, and on screen right is a thigh myxoid tumor. And you can see on both of those, you see those tail-like extensions going north-south. That's what we're talking about. That is tumor extending along the fascial planes. So if someone asks you what kind of a margin would you want for a myxofibrosarcoma, you're going to say a wider one. It's a little bit hard. You can't say like, well, it's 2 for some people, but 5 for myxofibrosarcoma. It's not that cut and dry. But if you tell them, I need a wider margin because I know it spreads along fascial planes, then they know your head's in the right spot. And that's why the MRI is helpful. You can't pick this stuff up on CT scan. These are contrast enhanced T2 weighted images MRIs. Yeah, it's imaging, Kai, it's imaging. And that's why MRI is so helpful in these extremity ones. So in this particular patient, this is a myxoid liposarcoma. Our margins, yeah, I would plan our margins based on the imaging. And that's what we're doing right here in this slide. I love it. It's like you're like my straight man. The anterior margin in this patient, even though this is a deep tumor, but it's pushing up against the skin and subcutaneous tissue. What that means when we're taking it out, we're going to raise our flaps at the level of scarpas. The radial margin of the tumor is exactly that. What is it pushing against that you need to remove? And if we're near the knee, that's going to be portions of the adductor because this is a medial thigh tumor. The sartorius, which is right around here, and the gracilis, which is also right around here, is part of that. And then the deep margin, you can see close to the knee, right there, is going to be the vastus, a portion of the vastus medialis, so part of the quadriceps, the semimembranosus, so part of the hamstrings, and then the fat around the knee joint. This thing is far enough away from the knee joint that we shouldn't need to take any knee capsule. But once we know in the operating room, we're planning to say, like, once I'm encountering knee capsule, I know I've gone deep enough. And this again is why the anatomy is so important. So what kind of functional deficits are you going to render the patient with that? If we are taking gracilis and sartorius, Kai, what kind of functional deficit would we leave the patient with?
Sorry.
Yeah.
Yeah. Like I could just turn on my mic, but I was typing already.
That's right, Kate. He won't be able to look at the dog poo on the bottom of his shoe. From a functional standpoint, people can live without the gracilis and the sartorius very easily. And then what about taking part of the adductor magnus? Would you notice much of a functional deficit?
Not with part of it, I think, but I think if you're taking it in conjunction with the others, you might notice a deficit.
He'll have some mild weakness, and you'll see it initially early on, but he will compensate very well. And then part of the vastus, medialis. Will you see any major deficits with that?
No.
Yeah, that's takeable. You can take any one of the vastus muscles. How many med students? Do we have any med students out there?
There's lots of med students out there.
Sweet. I'm just going to call randomly. Sorry, Corey Keenan, MS3. How many vastus muscles does someone have in their thigh?
Corey, I don't know the answer to that question, so don't feel bad if you don't.
So it's not close to the liver, which is why Tim doesn't know that.
You said how many vastus muscles?
The answer is who cares?
So the medialis, lateralis, and the what's it? Intermediate? Nah, it's not 4.
Yeah, very good. And then what other muscle completes the quadriceps?
The rectus, right?
Rectus femoris. So those 4 constitute the quadriceps. And what is their main function?
So the main function would be to hip flexion, I think, and
no hip flexion. No hip flexors.
Well, flexion of the leg.
Flexion?
I guess it'd be so you could have extension of the leg.
Yeah, extension of the knee. That's their principal.
Say again?
That's their principal function is knee extension.
Knee extension, yeah.
So if you take all of them, they're going to have problems extending their knee. How does that manifest?
issues, I don't know, issues with walking. They won't be able to extend their knee leg to walk, standing up.
In their knee, they're gonna have a hard time walking. So you need to make sure that they have a physical therapy consultant and get you know, braces and stuff like that. That's if you're taking all of them. You can take any one of them and the patient will extend their knee just fine. You can measure strength differences between it, but the way the body compensates is pretty amazing. You can take a lot of any one of, you can take most of many of these groups of muscles and the rest of the leg will compensate. But if you're taking all of them, if you're taking an entire anterior compartment, so taking all of the quadriceps muscles, then those patients need to see a physical therapist because they're going to have a lot of trouble walking.
Yep, makes sense.
Next, so that's planning a surgery, and that's how we think through some of it, and we'll go into some specifics later. Radiation, take-home points for radiation, decreases local recurrence in high-grade extremity tumors, no impact on distant metastases or disease-specific survival. This has been studied by several groups in randomized trials. This is one of the earlier trials of brachytherapy where we implanted radiation catheters into the sarcoma bed. At 5 years, there was a decrease in local recurrence for the patient, or sorry, there was an increase local recurrence-free survival, so fewer recurrences in the patients that got brachytherapy compared to those who didn't, predominantly in the patients with high-grade tumors. So, and that's on screen right. No difference at all in disease-specific survival, though. Why is that? Connor. So decreases local recurrence does not change people's dying from sarcoma.
I would think mostly because most of these don't, or many of these don't metastasize.
Many of them don't, but the brachytherapy had no influence on those who did. Does that make sense? So whether you got brachytherapy did not change your rate of metastasis. It changed your rate of local recurrence, which makes sense. Radiation is a local treatment. It's supposed to reduce local recurrence. The National Cancer Institute did a similar trial. This is with external radiation. Again, in the high-grade sarcomas, the patients who received post-op radiation, 20% of them had a survival advantage, but no difference in distant metastasis. So taken together, all the randomized trials we have so far of radiation and sarcoma is that adequate surgery actually still remains the most treatment modality. If you go back here, in the high-grade extremity sarcomas, 80% of people that did not get radiation had no local recurrence. It reduces the local recurrence, but not the distant metastasis or the overall survival. And so its major role is to prevent recurrences that would require amputation to treat. So Connor, knowing that, which patients would you consider radiation as a principal component of their treatment?
So it's a patient who would be at risk for requiring amputation if they were to locally recur.
Yeah, what kind of tumors are those?
Like specific histology?
No, not specific histologies. It's more of a location issue.
Yeah, so I think probably things that are near joints.
Yep. Or
near neurovascular structures.
Yeah, those are hard to get a margin on, right? If you're trying to avoid an amputation, you don't want to render the limb functionless. If a tumor is really close to the major arterial structures or the nerves of an extremity, or if it's on a high joint, so groins, so stuff that's close to the groin where it's close to the femoral vessels and the femoral nerve, those are tumors that very frequently get radiation. And then anything in deep-seated large, high grade, because if it comes back, it's going to come back on one of those structures, and the only thing you can do is amputate. And then histology is high grade, of course. A low grade tumor, its main thing is it comes back, but it very infrequently comes back. We've studied when to give it preoperatively and postoperatively. I think that's way in the weeds for your boards, but just so you know, when you give it preoperatively, we give them smaller doses. Patients get more postoperative wound complications when they get preoperative radiation, but that's really only in the patients with lower extremity tumors. And the reason to give it preoperatively is because of the smaller field and the smaller dose, they have less long-term complications. So their limbs get fibrotic, their joints get stiff, they have decreased quality of life. So if you give them a lower dose and a smaller field, you can give them better long-term quality of life at the cost of upfront wound complications. The big complications for extremity radiation are joint stiffness and then fibrosis, and then fractures, pathological fractures of the long bones. So in some of these patients, like this patient up here, this tumor is surrounding about 3/4 of the femur, and we would need to strip the femur to get it off. That's a patient that is really high risk of getting a pathological fracture because they're going to get radiation as well as a component of their care, and they're going to get their periosteum stripped. Sorry, here we go. Chemotherapy for sarcoma. Don't do it, but that's only because I came from Sloan Kettering, so the field is varied on this. When studied in randomized trials and in meta-analyses, there is a small survival advantage. We're talking 5% of patients absolute survival advantage. Let's have another medical student up here just so we can understand some numbers to treat. Who's Allie?
She's the PGY2 from UT.
Oh, okay. Allie. So if 5% of patients that get chemotherapy derive some kind of survival advantage, how many patients do you need to give chemotherapy to see one patient live longer?
Oh man, sir. I remember number needed to treat is 1 over absolute reduced risk or absolute risk reduction.
That's correct.
But calculating that would take me a lot longer than I care to admit.
Okay, so you have the formula, which is right there, and I'll tell you. So the absolute risk reduction for chemo, as best we can tell, is about 5%. So 1 over 5% is 20. So as best we can tell, 20 people need to get chemotherapy for 1 to live longer when it comes to extremity sarcoma. Now that some of this depends on the histology, but this is all comers, high-grade tumors. Low-grade tumors, no survival advantage at all. And in the high-grade tumors, it really depends on the histology. So Kai, to your point again, that myxoid liposarcoma that we talked about earlier, the one that spreads in a funny way, is also exquisitely chemosensitive. So this is a tumor that very frequently will get chemotherapy because we know that it responds very well to it, as opposed to an undifferentiated pleomorphic sarcoma, which has a very intermediate response to chemotherapy, as best we can tell. And there's some where it's like pissing in the wind. Well-differentiated liposarcoma, there's no point. Like chemotherapy does not help. We sometimes use it pre-op, and the reason we would use it pre-op is to see if we can shrink the tumor. So in a patient with a myxoid liposarcoma, pre-op chemotherapy is a strong consideration because we can take a large tumor and pretty reliably shrink it down so we can give the patient less surgery. Of the chemotherapy agents we use, anthracyclines, and in particular doxorubicin, are the backbone of the regimens. Is anybody familiar with doxorubicin and what it does to people?
Has cardiotoxicity.
Yeah, it can give people heart failure. What else? That's fine. The cardiotoxicity is the main thing we worry about, but it's hell to go through, guys. I mean, these are like people that they've lost all their hair, they feel miserable the whole time, and if you give them too much, you can throw them into heart failure. So sorry, now let's go into some cases. So that's the basics, right? So surgery, and when you're planning your surgery, you got to think about what you're going to change for the patient because you're going to be taking out a lot of stuff. Radiation helps decrease local recurrence for high-grade tumors, and you want to really consider using it when you're worried about your margin. If that margin is going to include something that gives the limb function, like a big artery or a big nerve, that's when radiation becomes very important. Chemotherapy does not help many, but it can help some, particularly people with like myxoid liposarcoma, and then the patients with rhabdomyosarcoma or Ewing's tumor, those pediatric kind of sarcomas, that's actually like the mainstay. So we treat them with chemotherapy first. So if you hear rhabdomyosarcoma, in general, think I need to get this patient chemo. So this is a first case. We'll just I want to go down the line. Nice. Molly from U-Shoes. Tell me what you notice about this patient's thighs. This is a retired NYPD detective who came to us because he was having some trouble walking.
Well, sir, it looks like one of them is markedly larger in size than the other one.
Yeah, he's got a big lump in his thigh. Which part of the thigh has the lump? The anterior, the medial, or the posterior compartment?
It looks to me more to be the medial.
Yeah, very good. And you can see how his hip is rotated out.
Yes, sir.
That's him. Like we didn't do that. This is our pre-op picture, yes, but that's the patient's normal state of being. This tumor is causing enough issues displacing his other tissues that he's rotating his hip to be more comfortable. So we get an MRI because that's the next step. And Ryan Carney, M3, what do you see on this MRI on the left side and on the right side?
On the left side, it looks to be in the medial compartment. There's some hyperintensity in the center of the mass. You can see it displacing the musculature laterally. And then on the T2 image, you can see it's hyperintense compared to the surrounding tissues. Seems to be heterogeneous. Yeah.
Yeah, very good. Going back to kind of our earlier rubric, is it superficial or deep?
So it's deep.
Good. Is it homogeneous or heterogeneous?
So I'd call it heterogeneous.
Good. This doesn't have any enhancing things, but you picked it right. This is the medial compartment. The boundaries of the medial compartment are here. This is the patient's anterior compartment. What are these structures right here? If they're between the anterior and the medial compartment.
The neurovascular bundle.
Yeah, that's the femoral artery. That's the superficial femoral artery and branches of the femoral nerve. That's exactly right. So your margin, when you're planning a surgery for this patient, how are you going to, what are you going to tell them about it? What are you going to tell them? I'm going to look out really hard for these things so I can preserve your leg function.
So to preserve the leg function, you're going to be making sure that you want to maintain first of all, the blood supply to the area, as well as distal to where you're taking your margins, as well as the nerves, so that they can maintain function. And then if it's in the medial compartment we talked about earlier, that you can probably get away with taking some of the musculature and they won't have as much functional deficit.
And what kind of functional deficit would you expect?
So they're going to
like just keep going. The reason we're keeping going is because you're doing great.
Yeah. So the reason you would, like we talked about earlier, probably some of the adduction, that motion like crossing your leg, being able to sit with your legs crossed, maybe some patellar tracking.
Nice. I don't even know what patellar tracking means. That sounds really fancy. Good job. Katrina Thomas, I am pointing out a structure in the posterior compartment that is by this tumor right here. I'll give you, it's not an artery and it's not a vein, but it is an important structure. Do you know what it is? This guy right here. It's over here too. Let's see, maybe on the, oh, can't hear you. I'm gonna assume you're trying. Bobby, what is this structure here? It's in the posterior compartment of the thigh between adductors and hamstring muscles.
Is that Is that a tendon?
Not a tendon. I'll give you, it's not an artery, it's not a vein.
Is that the femoral nerve?
No, it's not the femoral nerve, but it is a nerve.
Sciatic.
Sciatic nerve, good. So what does sciatic nerve do for you from a functional standpoint?
Innervates a lot of some of your hamstring.
And?
And parts of your lower leg as well. It gives off posterior tibial and
Yeah. It hits the gastroc pretty hard, yeah. So if you took out the sciatic nerve, what functional deficit would you notice?
A lack of ability to flex your knee.
Flex the knee? Yeah, if you took it high, but this thing is a low thigh mass, so I'm not worried as much about knee flexion as something else.
Is your hip flexion?
No, hips are even higher than the knee.
Okay, sorry. I guess foot drop. I mean, are you gonna get
foot drop? Exactly. So if you take the sciatic nerve out low, you get a foot drop, and that's something we need to counsel the patient on, right? Because it looks like this tumor is all up on that sciatic nerve, and I think that's going to be involved in our margin. Like, there's no way I can get this thing safely out without doing something to the sciatic nerve. Either pulling it to the side and protecting it if I can, or taking it. So question, can people live with a foot drop?
Yes. That's difficult, but yes.
Yeah. We'll get into that in a little bit too, because clearly it factors into this. Okay, so this is the same patient. You can see large heterogeneous tumor in the medial and posterior compartments. And on the far right side, that's the sagittal cuts. It's showing you that it's also encroaching into the posterior compartment. So we biopsy it, and it's a 20 centimeter myxoid liposarcoma. So Kate, what other staging studies do we get?
You're gonna have to listen to my dog growling a little bit because people are walking by, but
Your dog eats sarcoma too? That's good.
yeah, she does not like myxoid liposarcoma.
Neither do I.
So needs at least chest imaging, but then I think this was the one that you were saying you'd also do the full abdomen and pelvis CT imaging as well.
Yes, exactly right. And that's what we did, and there was no metastatic disease. Some people will also get PET CT because these things can light up high on PET, and they think that it can help them with metastatic detection, but that is not standard, or I should say that's not, it's not a strong recommendation by any group. The ortho-oncs here will do that. They get PET CTs basically on everybody that I've seen with extremity sarcoma. Just know that the CT, in my experience, in my opinion, is the more helpful of the two. The PET is a tiebreaker. So we do that. So we get the CT, the chest, abdomen, and pelvis, because myxoid liposarcoma can go to fat pads. And then the pre-op considerations, that tumor is getting close to the femoral vessels, but it's all up on the sciatic nerve. So this is what we did. This is a picture from his operation. Get that back. And then, nope, can't do that. So what you see is, this is the resection bed when we're done. We've looped out the femoral vessels and the femoral nerve branches to the vastus, and then high up to the hip flexors. And that way we were able to pull them away and get the tumor out, and then skirting along the femur, this is some femur with periosteum down here. And this is some dissected out hamstrings. The sciatic nerve was splayed out across it. There was no way we couldn't take it, so we took the sciatic nerve. And this is the stump of the sciatic nerve, which we injected with some lidocaine for some pain control, then tied off and tried to bury it so we wouldn't get a neuroma. So we have a question from Alyssa. Yeah, the patient fell in the subway and noticed the mass. This is a common presentation, at least in testing, and certainly a lot of people, like, they let these masses. The body compensates for a growing tumor very well. You can think about it pretty much anytime. Like pregnancy is a great example. The body compensates for the growing uterus for a long time before women start even showing. And the same thing happens with these soft tissue tumors. That's why a lot of them present when they're very large, because the patient hasn't been necessarily ignoring them. And, but, you know, finally it kind of comes to a head. They're like, wow, I really noticed that my leg is much bigger than in the middle part than my other leg. Maybe something's going on. So common, yes, and certainly on testing, they'll give you like, yeah, they fell and they noticed a lump and the lump's not getting better. Yeah, Kai, so yeah, we looped out all the vessels and we did a really nice vascular lysis and neurolysis. The femoral nerve branches in this part of the thigh are about the size of a pencil. So when you find those, you can sharp dissect along them and pull them out of the way. But in this patient, the sciatic nerve was just completely splayed across. It looked like fascia. It was so splayed across. It's normally a big cord about the size of, you know, my pinky or Vreeland's, you know, thumb, and like you can usually twang it like a guitar string. But in this one, it was splayed out like it was like a piece of fascia. So we couldn't take it out without taking out the sciatic nerve. So we did that. And this is this tumor specimen, big, nice, like a sarcoma. On the screen right, what you're seeing is the distal stump of the sciatic nerve and one of the tendons that we had to take with it, one of the hamstring tendons. And this patient got a foot drop. But this is how you treat it, Bobby, to your earlier point. This is a posterior foot brace. So this is his post-op visit to us. We got him fitted for this in orthotics and physical therapy. And this is how a patient with a foot drop walks. So this is him in his first like 2-week post-op clinic visit. So with the brace, pretty good. And I think he got back to doing his detective stuff with NYPD within about a month or two with some physical therapy. So, you know, we always like to preserve function if we can. There are certain things we can take and the patient will do fine. One of those is the sciatic nerve, as long as they get the brace. Okay, next patient, again, going down the line. A lot of thigh tumor. We got some other stuff coming up. Yeah, Kate, Diane, I'm not gonna do that. Tommy, you already did this. Corey, I think we already asked you. So Sarah, you're back up. Myers gets a pass because he has a young kid. So this is a man that comes to you, notice a lump in his right thigh. We did a biopsy in clinic, myxofibrosarcoma. Tell me about this tumor. What are you seeing? Superficial, deep, heterogeneous, not heterogeneous? Is it anything important?
So I would say deep, displacing the musculature, and I think this is still medial? Hard to tell in this image.
Medial thigh.
But he is, it's well circumscribed, heterogeneous, has some uptake on, I think this is T2.
So there's a contrast. The right side is contrasted imaging, which is generally T1, because T1 influences the contrast. Or sorry, the contrast influences T1 imaging.
Okay.
What do you see? How does it? Is it close to anything that that we can't take with impunity?
I mean, it's close to your femoral vessels. It's not completely abutting them, but it's close.
Yeah, so that's going to be a consideration for operative planning. And this is a myxofibrosarcoma. So going back to our earlier slides, what does that tell you about, our margins that we need to consider?
They need to be wider.
That's right. And so this is a sagittal shot, but that's that tail that we're talking about. This is just a representative shot. The high grade component is that kind of nasty like lump in the posterior middle part of the tumor. But there's that tail extending along a fascial plane here in the inferior portion of the tumor on this one cut of the MRI. So we're going to need to get a wide margin, and we know it's a medial tumor. What is the main muscle in the medial compartment?
Is this still me?
Yes.
The adductors, so Dr. Magnus probably.
Yeah, Dr. Magnus, brother. Of those three, which is the most important?
I'm gonna go with Adductor Magnus.
Very good. Always go with anything with the name Magnus. Any Scandinavian name wins. So, so that's what we knew. We knew going into this, we'd be taking out a lot of his adductors. We were going to try to preserve as much Magnus as we could while still getting an appropriate margin around it. Down near the knee, you also get the adductor longus and brevis. And so those are fairly takeable. So Kai, to get a wide margin, that's a budding fascia. So it depends. So for other sarcomas, the fascia is a great barrier to spread. So if you take the fascia, like with a mastectomy, so if you're taking that fascia with the tumor, that's generally all you need to do. With a myxofibro, though, it tends to go into and through the fascia. So not only do we take the fascia by the tumor, but we also take a rim of muscle deep to that fascia to include it as part of our specimen. But in general, outside of myxofibrosarcoma, the fascia is a great barrier to tumor spread. And if you take the fascia as your margin, 90% of the time, you're fine. Yeah, so Olivia, how much of a normal rim? That's right. I wish I could give you a precise number, but for most sarcomas, I try to do 1 to 2 centimeters. So in the operating room, I put my hand over the tumor and then I bovie to feel where the edge of the tumor is, and I bovie outside my hand. Peace. You remember that lady that we did the chondrosarcoma with thoracic in?
I do.
Your dog remembers.
A very adorable, fluffy dog ran by. Yeah, she thought it was very impressive too. I was hoping you were going to mention it.
So yeah, what was the move that I kept telling you to do when we were making our skin flaps and dissecting along it? From a technical standpoint, how did I tell you to do that? Do you remember? Please tell me you remember.
I'm not sure exactly, other than continually like kind of trying to make sure we were still pulling the mass away, because I think we ended up going wider than we had thought just based on initial imaging because of how the mass felt once we were actually there.
Yeah. That's exactly what I wanted you to say. Thank you. So the normal rim of tissue is a little bit hard to say, and it's kind of a feel thing. So at the beginning of the case, what we were doing is I put my hand, once we make skin flaps, I put my hand on the tumor gently, because you push too hard, like you can do other stuff to the tumor, but I put my hand gently on the tumor and then kind of take cautery around my hand. I know my fingers are 1.5 centimeters, so I know that's giving me at least 1.5 centimeter margin around it. And we keep marching our way down with a hand and doing cautery around your hand. So for the myxofibrosarcomas, I put my hand on the tumor and then I go wider. It's not very technical, but it's also the easiest way I can describe getting a wider margin than standard. And then wherever I see the tail on imaging, so for Olivia, so for this tumor, I know that this tail is going at least down the inferior aspect of the thigh. I'm going to do a very distal resection, meaning like I'm not going to take the muscle kind of close to the tumor. I'm going to take the muscle close to the joint in this patient, and that's what we did. So good access. Oh, go ahead. Frozen sections, generally not. Sarcoma is really hard to look at under the microscope in general, and frozen section makes it even harder. I don't know, Vreeland, did you guys do a lot of frozens on your sarcoma cases?
We did not. It's very much, like you said, a feel thing. You just kind of put your finger there and try to take a big whack.
Yeah.
Very scientific. That's what I love.
You just cut the stuff out. Yeah, and the reason is they're hard to look at under the microscope under the best of circumstances, so frozen's not typically helpful. So for these medial thigh tumors, I put up these pictures because this is a great way to access the case in a 2-person case. If we ever get to do this, this is what we'll do. Put them in lithotomy, tumor right here and right here. So surgeon or me stands in between the legs and the other surgeon stands on the other side. This is so this is the medial thigh after it's prepped and draped. So we take out the biopsy. This guy had a core biopsy, and we did the core biopsy in clinic so we could plan our incision right around it. So this is an ellipse of skin encompassing the biopsy site, and we've raised skin flaps to the sartorius anteriorly in the posterior compartment, posteriorly. So this is getting towards hamstrings down here. and sartorius up here. So we're looking at fat overlying tumor overlying the medial compartment right here. And then that, Olivia, to answer your question, this is how you get in that margin. So this is Dr. Yoon right angling me through the case like he always did, but he puts a hand on the tumor and then dissects past his hand. And it's that feel thing. So you know your hand is a centimeter and you're dissecting wider than that because you know that as soon as you cut through this muscle, it tends to kind of like contract and shred and it looks like you have a positive margin. It's very disconcerting in the OR. So you always want to go wider than you're expecting. And so hand on the tumor, dissecting past your hand, and then taking the muscle serially with cautery or ligature or something like that. This is that specimen, and this is kind of what they're supposed to look like here. So on the left side of the screen, that's the anterior surface. That's fat overlying muscle, overlying tumor. You can't see the tumor. That's what we want to see for a specimen. On the right side is the posterior side. The stitch is marking the deep margin. And again, you can't really see the tumor or its capsule, which is wide, which is exactly what we want to do. And finally, this is the field that we've left behind. Sartorius to screen right, vastus anteriorly, and adductor magnus. We were able to spare most of the adductor magnus. So this guy had almost no functional deficit immediately post-op. You lay drains because it's a big dead space. And for someone that's getting radiation, where do you want to leave your drain? Bonus points. Who's up? That's going to be Connor Chick. You already got it. Beth. If we're going to leave a drain here, where do you want to leave your drain? And what with respect to your incision? Your choices are close to, far away from, in line with, or out of line.
Well, I would definitely want my drain in like the radiation field if that's what I was doing post-op. For the patient's comfort, I would probably do it along the incision.
Close to or far away from?
Close to.
Very good. And why is that? I mean, besides patient comfort, which is right, patients are more comfortable when all of their incisions are kind of closer together. But there's something else about the radiation. If this guy's going to get post-op radiation, what are they going to radiate?
Do you mean what structures are they going to radiate?
How do they plan their field?
I know that you can leave clips, like surgical clips, to help guide kind of your radiation field. You also want the drain included. My thought was that you want the drain location to be included in that operative field because of that risk of like tumor seeding.
That's exactly right. So so you lay clips down where the primary was because they can boost or give extra radiation to that, but they will radiate your entire operative field. So they radiate the entire incision, the drain, and they also go wider past your incision because they know how far out you went because you talk with them about it. So it behooves you to spare the patient morbidity by placing the drain close because they're radiating that drain tract. So very good, Beth. Next, there we go. Finally, final case and going down the road, we got Christina. Here comes a 60-year-old woman with early satiety, and she says she feels full early. What do you notice on this CT scan?
That ginormous mass on her abdomen, pushing everything away.
So yeah, so we have a ginormous mass. It looks like it's fatty. Can you see that it's the same kind of gray as the gray around the bowel on the left side of the screen?
Yeah. So I guess that's like heterogeneous. It's more grayish on the right side of the patient, becoming more dark. I'm not really sure if it's like fluid or air.
Fluid or air, yeah. So what's that gray stuff? That gray stuff is hyper dense, so it's thicker tissue. So you're exactly right. It's fat. It's a big collection of fat, and it's got abnormal fat. That's what the lighter gray stuff is, abnormal fat, which is either something called a sclerosing well-differentiated liposarcoma or dedifferentiated. And in this particular patient, with something this big, it's a liposarcoma. It's fatty, and it looks, these big lobules, right? They look the same general color as this fat by the bowel, but this looks abnormal in that it's got these big lobules of it. It's got all these light-colored bands coursing through it. And then it's got this knob over here. So this is liposarcoma. well differentiated with dedifferentiated. So when you're operating on these things, these are this big belly wax. You make a monster incision, you clear out all the fat, you try to keep everything that looks like it's not obviously invaded. So the thing is, like, these tumors typically don't invade, but they surround a lot. So for example, the kidney. It's rare for these tumors to actually invade the kidney parenchyma themselves, but they will invest themselves into the kidney hilum and get around all the blood vessels and mess with the inflow. So you can't take out the tumor without buggering up the kidney anyway. They don't typically invade the bowel, but they will get all up on its mesentery. So it's very frequently with these left-sided tumors that they splay out the left colon or the sigmoid colon mesentery, and you can't safely get the tumor away from the mesentery without buggering it up. So we end up taking out the left colon in those cases if we can't think we can separate it from its mesentery. The ureter, same thing. They typically don't invade it, but they can really wrap around it. And so a lot of these cases are really tedious ureterolysis to get them things out. It's okay to ligate the infrarenal IVC, despite what Dr. Brandon and Dr. Huddle, or Dr. Proper and Dr. Huddle will tell you. The patient will get edema. They'll also get collaterals later on. You don't need to do it in all these cases, but for some of these retroperitoneal sarcomas, the safest operation is to ligate the infrarenal cava. So this is that patient. This is the view from anesthesia. We've made a big incision. You're standing at the head. Head's here, feet are here. Left-sided tumor that's kind of poking out. This thing right here is the sigmoid colon, and it's splayed out over it. It's pushing its mesentery. It's investing in the mesentery, and this is actually we've already divided the proximal end of the sigmoid colon, so we can get it out. And then you curve around it posteriorly. You work in a circumferential fashion. You just go with what you can see, and you gradually tease it out. And by the end of the case, next slide, please. By the end of the case, this is a slightly different patient, but this is kind of what, this is kind of what you're left at here. So in this patient, we took the kidney and we took the distal pancreas and we took the spleen and some other stuff, but this is what the tumor bed looks like in many of these cases. So the tumor bed is here. We have left the kidney behind in this particular patient by stripping off the abnormal fat from the kidney capsule, and it wasn't encroaching on the hilum, so we were able to dissect it from the hilum. This is the ureter. So we started low in this patient, and we just worked teasing the ureter off. It's off tumor, and then the psoas muscle. So that's tenderloin, and you're supposed to see that. And what we do in these cases, we also take portions of that muscle as a posterior margin.
So Rob, I just wanted to say one thing about that case, that last case. Can you go back to the CT on that one, Rob? The hard thing about these cases is, where's your margin, right? I mean, there's just no way that you're going to comfortably get a margin. And so what I was taught is it depends, a lot of this depends, and there's some subtlety to this, but when you have a retroperitoneal liposarcoma that's huge like this, and some of it's D-diff and some of it's well diff, you have to be okay with leaving a little bit of well diff on certain structures, like the kidney, because the reality is you're not going to get an R0 with a 1 centimeter margin on every corner of this thing. So why get it anywhere? And so you try to get it, yes, and you take out things that you can take out with low morbidity, but you don't, unless the kidney is like completely wrapped in D-diff, you try not to take the kidney out, like that picture Rob showed there of where you kind of strip the perinephric fat but leave the kidney behind. You just have to sort of have a philosophical approach to these where you're okay with leaving a little bit of tumor behind because you just know you're going to. You try to get all the D-diff stuff out, but you are often going to leave some well diff, and it's going to come back. And you just have to tell the patient that up front that, this thing's going to come back, and we'll watch it, and then 68 years down the road, we'll go take some more out. And, we had patients that we were taking back to the OR for the 3rd and 4th time to keep kind of chipping away at these well diff with D-diff components. But it's just difficult. But I think you can really hurt somebody if you approach somebody like this saying, well, I have to get a 2 centimeter margin, and you reconstruct the aorta and take out their kidney and take out, their bladder and all these crazy things. You just have to be sort of cognizant of balancing what you're doing right with the morbidity that you're creating.
So yeah, so Vreeland, it's on an important point, the natural history and the behavior of these tumors. That's why I keep stressing that histology is so important. The liposarcomas, both well diff and D diff, they're pushers. They like to push against things and wrap around things, but they don't tend to invade things until they get really out of hand. And so the surgical approach is to take it off and leave what you can behind. The natural history of these things is also they recur locally in 60% of patients, both of them. Well diff recurs in 60% and D diff recurs in 60%. It's the time course that's different. So well diff liposarcoma, it can recur 20 years later after you take it out. Almost all of the D diffs recur within the first 5 years. And so you know that these patients, in general, these patients are going to recur. So you're planning for that recurrence while you're doing the case. You do everything you can to shuck out all the tumor that you can and give them the best chance. But like Dr. Vreeland said, you're trying to leave behind everything that you possibly can because you know you're going to be in there again in the future. And some people do other things like we lay down separate film on the psoas and stuff like that. Some people do, not everybody. The other things that some people try is radiating in the OR to try to decrease local recurrences. The group in Boston is very adamant about that, but not everybody is. The colon, so Olivia, the colon is not the issue with these tumors. It's actually the colon itself is not the issue, it's the mesentery. And it's really hard to separate the fatty tumor from the colon mesentery, which is why we end up taking generally the left colon on these left-sided tumors, because we can't safely take the tumor away from the colon blood supply. So for these left-sided tumors in particular, but almost all the retroperitoneals, but certainly the left ones, part of their pre-op teaching is bowel prep, and you consent them for a possible colectomy with all of them. And so for the left ones, you tell them, like, there's a chance we're going to take out the kidney. There's a chance we may have to take out the pancreas and the spleen based on how it looks on CT scan. But and you have to be okay with that. I mean, I do whatever I can to preserve them. But these patients get bowel preps and they get consented for colectomies and all the other stuff. So yeah, but if you can, like Tim was saying, and like I'm stressing here, like you try to leave everything behind. So in this patient, we left the kidney, we left the ureter. We take the posterior muscle. Well, you know you're done when you hit the back muscle, when you hit the flank steak. All of the fat in the retroperitoneum is at risk because these are fatty tumors of the retroperitoneum. So we clear out all of that fat that we can. Some surgeons more obsessive compulsively than others. Like we had one, Sam Singer, who, like, if you weren't charring everything at the end of the case, he would start getting upset at you. But not all of them will. Other tumors, so that's retroperitoneal tumors, big wax, fun cases. Peace has gotten to do one, and I think she learned something from it. So other tumors that you will encounter, desmoids. These have no potential for distant spread, but they can be locally aggressive and cause lots of problems. The problem with them, we still don't really know how to treat them outside of surgery. 30% will respond to some form of treatment, surgery, radiation, medicine. 20% will respond to placebo. That's why I say they respond to water. 20 to 30% of them will shrink over time. So it is very reasonable in a patient with minimal or no symptoms and with a desmoid in an area that you can observe to just watch them. And in fact, I think the broader community is going much more towards that conservative treatment. We use MRIs. We started doing this at Sloan Kettering. It's not like high science, but the brighter something looks on T2 signal, so that's this tumor up here. This is a tumor with which is large and also has a very bright T2 signal. Those are desmoids that are less likely to respond to conservative treatment, and they're more likely to grow under observation. So these are patients in whom we would consider treating either with medicine or surgery sooner rather than later, as opposed to this one down here, which is not as bright on T2. Another absite trivia kind of thing, or sometimes when patients come to you in clinic, cutaneous leiomyosarcoma sounds very scary, but it's an excellent prognosis. 1 centimeter margins, they have very good long-term survival. And then dermatofibrosarcoma protuberans, it's another skin tumor. They'll come to you generally after excision in dermatology clinic where they thought it was a dermatofibroma, but then they got the pathology back and it's scary. This is a tumor, Olivia and Kai, that you want to get really wide margins on. This is a particular skin soft tissue tumor that sends out microscopic projections, like, you know, centimeters away from the tumor. So we're talking 4 to 5 centimeter tumors. Yeah, 4 to 5 centimeter margins. And those are patients in whom you want to get a plastic surgeon to help you out, or you better know some plastic surgery techniques to get them closed. Some final thoughts for y'all. Thank you for staying with me. With sarcoma and soft tissue tumors, get additional radiology and pathology help. These are very rare tumors. They require highly specialized eyes, both on MRI and under the microscope, to tell you what it is. So for here, like whenever I am in doubt, I actually email my my mentors at Sloan Kettering to see if they can look at some slides or look at an MRI with me to help out. Think about pre-op, what you're going to hurt the patient with post-op, and particularly like for these leg tumors or arm tumors that are up near neurovascular bundles, or you're going to be taking out a lot of muscle, have them see physical therapy pre-op. And just to set expectations, let them know that they're going to get through it, but they're going to, but they're going to have to work. And then in the OR, go wider than you think. always go wider than you think you need to. That's all I got for you guys.
One thing to add, Rob.